Mr. Moore, you recognize.
Thank you, Chairman, for holding this important hearing. Look, preventing chronic disease should be one of the most important things we do on this committee, and I appreciate the witnesses for being here today. Look, folks, we have a problem in this country. 42% of Americans have 2 or more chronic diseases. Treatment for chronic diseases such as cardiovascular disease, diabetes, cancer, and obesity cost Medicare and Medicaid $384 billion annually. Chronic diseases are a substantial burden on our health system, our economy, and they're obviously a detriment to patients. More than 40% of children are now considered overweight, and more than 20% of them are obese. Instead of a society-wide initiative to get kids outside, off screens, on a healthy diet of fruits, vegetables, macros, you name it, we have pediatric clinical guidelines recommending prescription drugs. We are the richest, most competitive, most innovative country on earth, and yet our life expectancy is going down. According to CDC, only 2 in 5 young adults are both weight eligible and adequately active enough for military service. Our healthcare spending is a leading cause of inflation and one of our biggest debt drivers, but the bottom line is our outcomes are not improving. The system isn't working. We have to do better. Dr. Peters, in your testimony, you discussed the importance of aligning payment incentives toward payment for health and prevention rather than sickness. Congress has taken several steps over the years to work towards this goal in the Medicare program through Medicare Advantage and ACOs. What additional ways can we incentivize value-based or outcome-driven care in the commercial market to prevent the development of chronic diseases?
Well, I think that's a tough issue, and obviously one that requires people have consistent access to care through their insurers, and maybe creating plans where people have insurance that lasts over longer periods of time. But I think we need to take some of these things that are best practices that you've heard about and try to use those and put them in other settings, such as the DPP program, which we know has been shown to work for prevention of diabetes, and then maybe augment it and try to help using some of the newer technologies and tools that we have that might make it easier for people to understand the impact of food and nutrition on their lifestyle. And I think there are more sort of technical answers that my economist pals at the Schaefer Center could also give you to answer that question more fully.
Senator Frist, anything to add to this?
No, I think the commercial market, the challenge there, of course, is the fact that there is a lot of spinning from plan to plan to plan. So we do need to figure out how to get the data to be able to follow patients over time in order to be able to measure what interventions work and to measure outcomes. Value-based care is outcomes sort of divided by cost itself. Traditionally, those outcomes have been things like readmissions, coming to the emergency rooms. We need to move that back upstream and look at things like the root causes, the public health model of root causes, like food itself. We just didn't set it, Medicare was not set up that way, and we need to change that over time. And we've not looked at, truly since 2018, the BBA, we have not really looked at food and nutrition as a root cause today the way that we should do in the dual eligible population, the population of Medicaid and Medicare, those 12 million people. We've not changed anything. That is where much of the chronic disease, about $500 billion is, and it's a little bit beyond the jurisdiction of this committee, and it's the challenge the way Congress has committees organized, but that overlap of Medicare and Medicaid, dual eligibles, 12 million people, $500 billion, much of the chronic disease, we need to have integrated care there. And that's where the value-based care will have its greatest impact.
Narrow that down to me. In your mind, legislatively, what can Congress do? It wasn't set up this way.
Yeah.
Medicare wasn't set up this way, and to change it requires a catalyst.
Yeah.
Because we just let it continue on in perpetuity, and it's the most noxious thing that I deal with back in Congress. What can we actually do to create some change on this?
Yeah, that's, I mean, really simple thing, having sort of, again, been on that side. I would set up a hearing very quickly. What I just said about the dual eligibles is beyond your jurisdiction, and this is health versus health care. Much of what we talk about is health care. We're talking about health, which comes into the social determinants themselves. So the first thing I would do is set up an integrated hearing between the 2 appropriate committees in the House to look at those 12 million people. I just told you it hadn't been changed in 5 years, and say, how do we get an integrated model of health and health care and value-based care, and have that discussion for the first time in Washington, D.C. in our government.
Thank you. Dr. Hyman, quickly, you've led the charge on food as medicine. How do we incentivize better diet through health care without the mandates?
Well, I think a lot of it has to do with knowledge and education. I've been shocked at how little people, even educated people, know about what to eat or what not to eat. I think that's a result of the confusing amount of information in the media and in science. Nutrition science is funded 12 times more by the food industry than by the NIH. I think one of the key strategies to work around is behavior change, and I think this is something that we do know a lot about because at the end of the day, it's about behavior change and how do you incentivize that. We discussed the social determinants of health. I learned from Paul Farmer, who treated TB and AIDS in Haiti, using not better medications or surgery, but by using the power of community health workers to help people change their behaviors. And I scaled this model to the Saddleback Church in Orange County, California with Rick Warren, where we got 15,000 members of that church to do a lifestyle change program in small groups, not run by a doctor, not run by a nutritionist or any healthcare provider or health coach, just a curriculum that was supported by the church. In little groups every week, they lost 250,000 pounds in a year and transformed their lives and got off medication, ended up, reducing hospitalizations. We scaled that to Cleveland Clinic, where we created a Functioning for Life program and showed that we have 3 times better outcomes for the same patient with the same diagnosis with the same doctor, simply by using the power of group therapy. Janet, I mentioned to you, she was in a group program, a lifestyle change program. If we reimbursed for things that work and behavior change strategies, it's really around understanding the nature of these social models of change. And I think the blue zones is an example. They're a natural environment, and I've been there. I wrote a book called Young Forever about these blue zones where they live in ways that automatically create health. They automatically eat healthy food. They automatically have to move because they live in rugged environments. They automatically have social connection and meaning and purpose in their life. These are the things that drive longevity, not genes. And so those are the things that we can replicate. You're more likely to be obese than if your friends are overweight, then your family's overweight. You're 171% more likely to be obese if your friends are overweight than if your family is 40%. So this is something we actually can do and reimburse. So the reimbursement for these group social lifestyle change programs, I think, is a very important thing that we could implement.
Appreciate it. Thank you.